It's May 16th, 2025. Hi, I'm Jack Cush with the Me, Myself, and I podcast. What? Yeah, you know what podcast. This week on the podcast, good news with cannabis use. Good news, steroids are going down. And good news, less opioid deaths. It's a podcast of good news. Welcome to the Room Down podcast. But first, we're going to begin with a report, regulatory reports, and I have two of them. The CDC this week announced in its analysis of overdose deaths in the U.S. that in 2024, overdose deaths dropped by 27%. In 2023, it was 110,000, and in 2024, it was only 80,000. There are numerous reasons for that. One of the biggest drops was in fentanyl overdoses. And education and some legislative changes. And these are very welcome changes. Yet, the problem remains. Overdose is still the leading cause of death in Americans age 18 to 44. So more work still to be done. Another announcement this week from the FDA recommending caution and maybe holding off using the chikungunya virus vaccine. As you know, we've talked about the chikungunya virus, prevalent in, it's a mosquito-borne illness, prevalent in the Caribbean and temperate climates. There is like a year ago, we announced a new vaccine. Actually, there are two new vaccines. One's called Ixchiq. It sounds like the name of a town just past the reservation, you know. That was approved in 11/23. But they're now saying hold off on using it because they've had some serious post-marketing safety reports, namely 17 serious adverse events, mostly neurologic and cardiac, including 2 deaths. These all occurred in mainly elderly people with chronic conditions. A third of them occurred in the United States. So there isn't widespread use of this vaccine yet, only about 80,000 doses since its approval, but nonetheless, that needs further investigation. J&J announced this week the results of a phase 3 Iconic Total trial. That's their study of icotrokinra. We always struggle with the new names. Icotrokinra. This is a drug under investigation. It's an oral IL-23 inhibitor. It's being studied in psoriasis. And this study that was presented, I guess, at actually just a press release, talks about the results of a 311-patient trial looking to see if the oral IL-23 inhibitor would have effect on difficult-to-manage scalp psoriasis and genital psoriasis. And overall, success was seen in 57% skin clearance in 66% of the scalp lesions, and genital psoriasis improved by 77%. These are all substantial improvements in a difficult-to-treat subset of patients with psoriasis. That's with icotrokinra from the Iconic Total Phase 3 trial. I posted up this week a report and a suggestion that maybe this is an important paper to look at. The number 2 most downloaded paper from the Journal of Clinical Medicine in 2024 was titled IgA Vasculitis, parentheses, Henoch-Schönlein purpura, an update on treatment. And it's a nice review of HSP. As you know, it has a bimodal distribution in kids and then in adults. But they say that steroids are first-line treatment, especially in adults who have severe IgA vasculitis. But they note that there are many other studies, and most of them are uncontrolled. So the reliability of these are, I don't know. But there are other treatment options beyond steroids, and that includes colchicine, dapsone, hydroxychloricquin, methotrexate, leflunomide, calcineurin inhibitors, and mycophenolate, even rituximab, even IVIG. The list goes on and on. I think what we're really saying here is that nothing really works, or that these people are difficult to treat. Maybe it's why this kind of paper is worth reviewing. Another report on vasculitis was a meta-analysis of patients with ANCA-associated vasculitis who also happen to have interstitial lung disease. So this is a bad complication in any of our disorders, whether it's RA, lupus, myositis. Anyway, this meta-analysis, 8 studies, 654 patients show that there's a significant mortality risk associated with this development. And it's especially so and significant the more age or the older the patient. If they were ever a smoker, 61% increased risk. If they have UIP pattern ILD, twofold increased risk of death. A history of acute exacerbations, and a background of microscopic polyangiitis, a 4-fold higher risk of death associated with ANCA-associated vasculitis and the development of ILD. Not good. I found a very odd publication from the Baylor University Medical Center, which I was associated with for a long time. I still think is a great center. They have their own Baylor Proceedings Journal, and there's a report in there that's an analysis of the national inpatient sample. It's a retrospective study of RA patients. And they looked at the ones, these are patients who would therefore have been RA patients who would have been hospitalized, and they compared those on cannabis to those not on cannabis. What? Now, how that was discerned from the NIS data set, I don't know. But in their report, RA patients on cannabis had a significantly lower mortality, 50% lower, odds ratio of 0.50. That was significant. A significant reduction in depression by 53%, chronic pain by 55%, anxiety by 45%. But this cohort also tended to use more opioids, a 10% increase, and more nicotine. So while, the lifestyle maybe and the psychology that goes along with cannabis use in RA patients may have certain benefits, it is also the lifestyle of cannabis use with more opioids and more nicotine that may be problematic in some. So I think I want to see data like this. Not that this is great data. It's from a large sample, and it's from a third-party sample, so it wasn't built to do this. As you can imagine, advocates of cannabis are widely touting this kind of research, Normal and others. But we need more data to know about the safety and potential benefits of the current trend for widespread use of cannabis for no reason or medical reasons. Between 2005 and 2021, a Swedish study shows in a cohort of nearly 4,000 lupus patients, there was a significant increase in hydroxychloroquine use, but a modest decrease. So over 5 years, I guess that's 15 years, glucocorticoids dropped from 68% to 54% to 46% as chronic therapy. That's pretty good. Hydroxychloroquine, however, increased by 29% during the same period. So in lupus, these are very welcome changes, are they not? So as you know, this week and this month, we are doing a lot of lupus news. Some of the highlights also include an article about trends in lupus and drug use. So methylprednisone followed by low-dose steroids is basically the recommended regimen. It is currently recommended by the ACR lupus nephritis guidelines. Risk factors for flare when you're starting to withdraw glucocorticoids in lupus patients include high disease activity, active serologies, younger age, shorter remission duration, faster tapering, and shorter duration of hydroxychloroquine or cessation of hydroxychloroquine. All that's very, I think, common sense, is it not? Don't be stopping steroids when basically patients are very active, very young, very uncontrolled, or you're stopping hydroxychloroquine or lowering hydroxychloroquine. It doesn't make any sense. A single center study, I like this because it talks about cytoplasmic staining on ANAs. This is a single center study of 2741 ANA tests. 65% were ANA negative, 31 were ANA positive to the nucleosome antigens. They had nuclear antigen staining, but only 2% had exclusive cytoplasmic staining So an ANA negative with cytoplasmic staining, or ANA positive but only cytoplasmic staining. I'm not sure how that's worded. And it was, 10, 15% that had nuclear staining and cytoplasmic staining. When they looked at just the cytoplasmic staining, they were either due to reticular, dense, fine, speckled patterns, reticular or dense fine speckle. There's two different patterns. The reticular pattern was more often associated with other diseases, especially primary biliary cholangitis, which had antibodies against the M2 antigen. And then the dense fine speckled was mostly associated with lupus. So cytoplasmic staining can be a part of lupus, but when you see it, you should be thinking other diagnoses or variants of lupus like SCLE and other things. I think this is a nice report. The big report of the week was probably the publication of the ACR 2024 guidelines for the treatment and management and evaluation of patients with lupus nephritis. This was a big hit at the ACR 2024 meeting, and I just want to give you the highlights of this and a few points. They basically say that if you have newly diagnosed or you're instituting treatment for a flare of lupus nephritis, they should get intravenous glucocorticoids, pulse steroids, followed by an oral glucocorticoid regimen that basically is weaned down, right? And that everyone with lupus nephritis should be on triple therapy. If they have class 3 and 4 disease, with or without 5, they should get one of three options. The top option is, and actually all of them get mycophenolate. No, actually, a few of them get mycophenolate. Mycophenolate plus belimumab is the top option. And the triple therapy is therefore steroids plus mycophenolate plus belimumab. They consider steroids one of the triples, okay? The second option is steroids plus mycophenolate and a calcineurin inhibitor. Third would be this oral low-dose cyclophosphamide, the Euro lupus nephritis regimen, plus belimumab, okay? So, and then if they're on cyclophosphamide at the outset, then you wean in mycophenolate after you stop the cyclophosphamide regimen for 4 or 6 months. If they have class 5 nephritis only, then it's triple regimen with steroids plus mycophenolate plus a calcineurin inhibitor. A few key points. The guideline, it says kidney biopsy. Kidney biopsy, kidney biopsy. If you don't get it, you're guessing. If they have extrarenal manifestations, they recommend a triple regimen therapy again that contains belimumab, and they prefer that over a calcineurin inhibitor for extrarenal manifestations. They conditionally recommend a target dosing of mycophenolate to be 2 to 3 grams per day. And if they're non-responsive or refractory, then you're really out on a plank there, right? You need to, if you're on dual therapy, go up to triple therapy. If you're on triple therapy, you consider alternative therapy like the CD20 monoclonal antibody rituximab, but that'll be changed in the future if we get obinutuzumab. What else? We have a nice report this week from Catherine Sims from Duke University, where she was at the pregnancy and lupus meeting in Vienna this week, covering it for Room Now, and wrote a few good articles. I like her article where she compares the recently published EULAR 2025 guidelines versus the ACR 2020 guidelines on the safety of lupus medicines during pregnancy. And a few points, drugs that weren't considered in 2020 are now sort of recommended in severe cases. That includes anifrolumab, Benlysta, or belimumab, but not voclosporin because there's still not enough data on voclosporin. They strongly, again, the EULAR recent guidelines strongly recommend against the use of leflunomide and methotrexate, and especially against the clear-cut teratogen, which is mycophenolate. They do say that you can use azathioprine. Both of the guidelines say azathioprine's okay. Both of them say that cyclosporin and steroids are okay. Both of them strongly recommend hydroxychloricquin. So I think, and even rituximab could be used, according to the new EULAR guidelines. So a useful publication, one you might want to reference if confronted with how to manage a lupus patient who has active disease and needs treatment. I wrote a blog this week on hydroxychloroquine for everyone. And I was really saying hydroxychloroquine for RA, everyone should get it. And I wrote a blog because 25 years ago, I used to say hydroxychloroquine is the most useless medicine in rheumatology for RA, meaning it was modest. It was modest. And I've changed my thinking. And I've changed my thinking really because of a plethora of reports on the efficacy and safety of this drug, especially in lupus, where it's been shown to lead to less lupus flares, better disease control, improved survival, less pregnancy loss. It has antithrombotic effects, which has greater mortality and cardiovascular outcomes. It has anti-diabetogenic effects, and it significantly lowers plasma lipids. And the fact is, while we know all of this for lupus, and it has now become a standard of therapy, everybody with lupus should be on hydroxychloroquine, you can say the same thing for RA, where it's been shown for all those things, remission, flares, cardiovascular events, less thrombotic events, less incidence of diabetes in RA patients on hydroxychloroquine. There's no reason that we shouldn't be using hydroxychloroquine in everyone with RA. Why? Because it's effective and incredibly safe, and it's cheap. That it has these same benefits as has been seen in lupus. And it really should be used in chronic inflammatory disease states like RA because it prevents a lot of the comorbidities that accompany these diseases. And lastly, RA is incredibly hard to control. I'm looking for an edge that I can get better control of my RA patients and a higher percentage of my RA patients. It's my Moneyball approach to RA, and this is one of the things I strongly advocate for, which is everybody should be on hydroxychloroquine. We have two cases from Ask Cush Anything, Dr. Ali Jawad. Sorry, Dr. Jawad, I didn't get where you were from. He asked a question about a nausea with methotrexate, that you take methotrexate and the patients report a few hours later, and for the next, half day or day, they have nausea. And the answer to this is pretty simple. Number one, lower the dose or stop methotrexate. But I don't usually have to do that. The big mistake most people make is say, well, I'm going to split the dose and let them take half in the morning and half at night. And split dose oral is the same as once weekly IM. You're delivering more medicine. You're getting better efficacy, but you also get more toxicity. So don't split dose oral. Don't go IM. Lower the dose or add vitamin A or dextromethorphan. Vitamin A, 8,000 units a day, every day, significantly lowers the risk of oral ulcers, some nausea, and other GI complications like diarrhea. On the other hand, nausea could be more of a central effect rather than a GI effect. And that can be mediated through NMDA receptors in the brain and can be blocked by giving dextromethorphan. I like using Mucinex DM as a pill, and you just take it with methotrexate once a week. So I have my patients take methotrexate at night. I usually have them take it with the DM, Mucinex DM at night, and then the next day they take another pill 12 hours later. Sometimes they need a third pill. But these work in like 70% of cases, these two manipulations. Again, you can try vitamin A. If that doesn't work, you can try the dextromethorphan. They're cheap, they're easy, and they work. Check my website to find out why that is. Another great complicated case from Marissa Meissner from the Geisinger Medical Center. Thank you, Marissa, for this case. 44-year-old male who started with arthritis at age 39 with pain, swelling, warmth, redness in the MCPs, PIPs, and wrists. The patient also had knee and shoulder pain at one point, responded best to steroids, responded some to nonsteroidals, and again, the problem has been all the treatments she's given have not quite worked. And the main pains and problems have been in the hands, best responding to prednisone 10 to 15 milligrams a day. So what do you do with this? Again, what she did was she did x-rays. And x-rays showed mostly OA findings without clear evidence of chondrocalcinosis or pseudo-gout. She did a dual energy CT scan that also showed chronic slack wrist changes, but also changes that did suggest CPPD arthropathy, including traumatic damage to the scapholunate ligament. So the patient has been studied further by hepatology and found to have a gene mutation for C2A2Y. This is one of the gene mutations associated with hemochromatosis, but workup did not show an iron overload state. So is this hemochromatosis? Is this just a heterozygous gene mutation, maybe with a hint of hemochromatosis, which could lend credence to the diagnosis of CPPD? The patient has been treated and failed treatment with adalimumab, sulfasalazine, methotrexate, etanercept, colchicine, all changed and stopped for lack of efficacy. Anakinra is the only drug that has had some effect but not complete. You need anakinra plus steroids. So what's the diagnosis? What's the treatment? Again, this is a tough case. I don't think it's RA because of the lack of response to RA therapies. The patient is seronegative for CCP and rheumatoid factor. And you don't get a picture of articular erosions or synovitis here. It seems to fit with CPPD and is a hard-to-treat case. And in those cases, my mainstays are steroids, colchicine, methotrexate, and anakinra. If anakinra works but not completely, it's because anakinra has a half-life of 6 hours. And maybe you would do better on a longer-acting IL-1 inhibitor, canakinumab, but getting that approved would be a little bit difficult, but you could probably do it by writing a long letter and providing some references. The gene mutation at C2A2Y suggests a possibility of hemochromatosis. There are also associations of this gene defect in patients with beta thalassemia. And when looking this up and finding this, I was a little surprised to see that beta thalassemia is associated with RA, autoimmune arthritis, inflammatory arthritis, etc., and it looks a lot like RA. So I don't know if this patient has something that looks like sickle disease, but a hemoglobin electrophoresis may prove useful. Obviously, if the hemoglobin electrophoresis is abnormal, I would get the hematologist involved. If not, I would involve the hepatologist to further evaluate hemochromatosis, and I would still treat this person as if they had calcium pyrophosphate deposition disease. Really difficult case. If any of you have a great suggestion, email me, and I'll pass it on to Geisinger Medical Center. That's it for this week on the podcast. Tune in next week.